Those of us here at Colorado State University are proud to share with you this session of Endoscopy Talks. When you're looking for inspiring veterinary CE experiences, think CSU Vet CE. Nestled up against the Rocky Mountains in our new State of the Future facility, we invite you to experience what we call CE Elevated. We'd love to see you in one of our future on-site, online, or blended courses. Check us out at www.csuvetse.com. Now, please enjoy Endoscopy Talks.
Hello, everyone, and welcome to Endoscopy Talks. I'm Dave Tweed at Colorado State University, and I'd like to thank you for joining us on behalf of Colorado State University's Translational Medicine Institute. I have just a few housekeeping things to talk about. This webinar is being recorded. The recordings will be available at endoscopytalks.com for viewing in the future by anyone at any time free of charge. There are currently over 35 previously recorded talks available for viewing covering everything there is in endoscopy. Also, your microphones and cameras will be disabled during the duration of the seminar, so you don't need to worry about being seen or heard. However, we would very much like you to submit questions for the speaker during the presentation at any time by simply typing your question in the Q&A window. You can find that window by hovering your mouse over the bottom of the Zoom screen. And we'll be asking the speaker as many questions as possible during the time we have. And most importantly, I'd like to thank the speakers for their contributions to this Endoscopy Talk series. Each speaker has volunteered his or her time to present their talk. So we're very grateful to each of them, as this series would not be possible without their generosity and expertise. So today we're joined by Dr. Paolo Martelli. He holds a certification in zoological medicine, part of the Royal College of Veterinary Surgeons, and is a diplomate of the Asian College of Conservation Medicine. He has worked in Singapore Zoo and Night Safari and is currently chief veterinarian at Hong Kong Ocean Park. He discovered endoscopy in 1995 and started using it on his zoo animals at that same year and has been doing so since then. He's done some amazing things, and once I even got to watch him endoscopically sex some large tortoises in Thailand. Dr. Martelli is going to discuss portable endoscopy and zoological medicine. So without further delay, I will turn the session over to Paolo.
Yes, thank you for having me. Thanks for the kind words of introduction. Actually, I'm a little bit out of my league here talking to real surgeons in a high-level series of talks, but I'm really happy to share things on zoological medicine and endoscopy, two things that I really enjoy doing. So I will be covering these topics. I'll give you a bit of an outline of what zoo medicine, zoological medicine is, because I think not everybody's really familiar with what it involves, and especially I'll try to clarify why it's a really good fit for endoscopy. And then along the way, there'll be some illustrations of specifically what the advantages, the versatility and the portability of endoscopy mean to zoological medicine. I started working, like Dave said, quite a while back in zoos at the time where very few vets wanted to work in zoos. There were a handful of useful books only. I counted 3 that were really constantly, regularly useful. They cost about half a month's salary each, so maybe that explains why not many people wanted to work in zoos. There was long before the time of internet, mobile phone, PDFs. There were no personal computers. The department maybe had a computer to share and so forth. One thing there was more of was animals and wild places. Always feels like things were better off yesterday in that respect. That's because they were. To give you an example, this was a regular weekday at the Singapore Zoo at the time. We would receive animals either from the environment, confiscated by the police or rescued from difficult situations, or confiscated at the airport, the harbor, and we'd get bags full of pythons, cobras, king cobras, we'd get pangolins, the occasional civets, and so forth. So that's just 15 to maybe 20 years ago. But if you look back in 1930, they still had tiger. This is actually the last tiger that was shot in Singapore. And less than 100 years before that, the claim by Wallace is that there are always a few tigers roaming around and they kill on average a Chinaman every day, his words. So one thing we realized, I realized quickly when working as a zoo vet, especially fresh out of school, is that there are very many gaps in knowledge, your own obviously, but also just knowledge in general, things you don't know because nobody knows. And when you have a clinical case on the table there for you to look at, filling the gap is not the priority, solving the case is. You also realize there's just too many species, too many procedures to really develop a career where you'll be mastering anything. So you might, if you're lucky, get jack of some trades and forget about really being good at anything. Also, the type of patients and the type of work and the resources you have means that your diagnostic plans, your treatment plans should be really, really simple, short, and that follow up, going back to the patient, isolating the patients for complicated tests are very rarely an option. Thankfully, common things are common and most common things are fairly simple. So, regardless of the species, there's a polar bear, but his problems are alopecia. I can't remember what this one had, but obviously something a bit more troublesome. This one was just a caracal kitten with diarrhea that needs some supportive care. This was some cosmetic work on a bongo who broke a horn. So most of the things you can handle without having very specialist knowledge. And also, even when you need more invasive procedures for diagnosis or treatment, you don't necessarily need access to state of the art, or now I just heard state of the future surgical facilities. For example, in this case, a Prevost squirrel that comes in feverish with a distended abdomen. With a century-old technology, your sensors, and a couple of lab disposables, you can perform a proper diagnostic and prognostic and treatment plan. So that's the good thing. You try to do procedures that need to be done only once and solve the case, or help the animal finish solving the case for you. So trauma is obviously one such thing where most of the time you can do that with a simple spay kit on one occasion. Other things that may be a bit more sophisticated. If you have a red kangaroo, you're not going to start a treatment plan with 4 different eye drops 4 times a day each. Just a nucleate, again, spay kit will do. If you have a zebra, especially a male with a fractured femur, you just need to put that animal to sleep, and you don't need much sophistication in the equipment for that. But clearly some things cannot be solved. So I don't want to give you the impression that everything in zoological medicine is a one-time action or can be done. We can do sophisticated things. For those of you interested in the extreme, you can go and look this publication up. We kept an animal anesthetized for 3 weeks to solve that one. This is obviously adenocarcinoma in a mountain lion. That is not something that can be solved easily and just once. Another thing you learn is that if you want to take pictures where you're smiling with your surgical case, do it immediately after surgery, because the animals sometimes sabotage your work. Another thing that is very obvious when you work in a zoo or with zoological species is that you must be able to have portable expertise. Even if you had the resources or a nice hospital, you can't always get the patient there. The size or the nature of the injury is such that the animal would not be able to make the trip there. So in this case, for example, big boy Samba deer that had a bit of a disagreement with another big boy, you see, this has to be fixed on site. Which brings about a number of things where endoscopy will come in useful later on. I want to introduce the ideas of aseptic conditions. You can imagine that there's only so much you can practice in terms of asepsis in a situation like this. And you have to be working on site. Other things are simpler, straightforward, like this was a simple spay of overrepresented lioness done in the back of house, done well. but no follow-up, no control on the animal after the surgery, and it eviscerated, and we had to do more. So this animal actually survived, but it had a very unpleasant 2 weeks to follow up on that simple surgery. Other simple things that become a little bit more difficult when you do them in the field, cryptorchidae, and this one is also here to slowly bring about the endoscopy. In spotted hyena, it's hard enough to tell boy from girl. You see that they look very similar. And if you have a cryptorchid, the testicle, as you know, it can be quite tricky to locate. In this case, it was where you hope to find it. But in situations like this, that's where you wish you had that's when you realize there's a genie coming to tell you, if only we had used the endoscopy. So we did look into that early in the 90s. We started making friends with STOR's representatives in Singapore. We met some human surgeons who were also pushing for the technique in human hospitals. The one that we were able to afford the third volume of the Fowler series that has a couple of pages on endoscopy, and we bought a system with much discount and recuperating bits and bobs that the human surgeons stopped using. For the older in the audience, you can recognize the VHS tapes. I'm not sure young people know what those are. And then, it opens a whole new world. Suddenly you can do your procedures faster through smaller opening. You don't have to really be concerned about post-op care. And the size of the animal is less of a limitation from the very small to the very large. And you can get away with far less strict surgical aseptic conditions. And we'll talk more about portable later here. Another good thing of endoscopy is that, let's face it, it's really simple. It's very easy. It's very versatile. So for people like us confronted with many species, many procedures, who don't have a chance to practice them over and over again to excel at anything, this is perfect. And the basic skills you need, you don't even need patience to practice. It's not like ultrasounds where unless you scan 1,000 livers, you're limited. Here you can go into a box as many times as you want, and you develop most of the skills you will need to then do the surgeries. The rest is visual, and you can see the actual organs. So it is a really simple tool to use. In spite of the sophistication of the equipment itself, it's not a complex thing. So this is not something I'm proud of. Actually, you can see my colleague disapproving of the situation. I'm even covering my face here. But just to give you an example, this is a liners that when we knocked it down in the field for diagnostics, we realized if we wanted to have an answer, we'd need to do an X-lab. And suddenly, because we have the equipment, we can just put in the back of the van, take it back to the hospital, wipe the instruments in alcohol, and get in and have a look and have a treatment plan. And a diagnosis, we can take biopsies and so on. Obviously, you wouldn't plan it this way. You wouldn't plan to do such a dirty slapstick surgery procedure, but it's possible. You try to do things a bit more sophisticated, and you realize that suddenly also you feel like a better vet because you do much finer diagnosis. An ectopic pregnancy, I can kind of guarantee you I would have missed this diagnosis if I hadn't actually seen the organs, and I think most people probably would. This is in a macaque. This you could see with an ultrasound, but the ultrasound would cost you as much as the endoscope, and you would need dozens or hundreds of hours of practice as opposed to just going and look once. Opens up a whole different series of patients. Also, surgery in fish is possible, but the surgical scar is always an issue. So this is one of those cases where the smaller the scar is also much better, and that obviously helps. We can put very small scopes through, and we can even do GIT examinations. Just one advice: if you're doing GIT exams in fish, don't stick rubber instruments, even in mouse that seem to have no teeth, because they have teeth in the most unwanted places. Other examples of what can be done here, the animals sometimes can be longer than most scopes. So we have a 3.2 meter gastroscope. In a 4.5 meter snake, the stomach's about halfway through. So you need most of the length of the scope just to get there. You can look at the lungs of snakes that are usually not very accessible, and you can look through the entire length with a decent scope. We don't access it this way. This is just to show you the structures. That those are the air sacs. We would just inflate and punch through with trocar and then pass the flexible scope through the sleeve. So it's, again, very simple, very intuitive, and you can actually have visual and sampling done on that. A few notes on birds, but I think there's some very good talks on bird endoscopy, so I'm not insisting much. Just to mention the zoological medicine resources, as money, cash is often an option. And genetic sexing of birds is expensive. It's about $20 a piece. So when you have animals that are not really that valuable, like in this case crested pigeons, it would be kind of a wasted resources to sex 100 animals genetically. And once you have their gender, you just have part of the information you're looking for. If you do it endoscopically, you can actually do a repro assessment by looking at the organs. You can see here's the crested pigeon. It's just a small fellow, but there's a decent access to it, and you can do many in a day. We can also show you some other examples where endoscopy comes to help of a more sophisticated procedure. This was a harbor seal that had a persistent postpartum metritis, and then doing some further examination. You see on the screen some hysterographies and some ultrasounds. We could see that there were tumors, and then by doing a mucosal biopsy with a flexible scope, we confirmed that they were leiomyomas. So we decided this needed an OVH, and we made a model so that we could practice the procedure, have an idea of what we would be facing during the procedure, which was kind of almost exactly what we encountered then when we did it, and cost nothing, and you can practice as many times as you want, positioning the animal, etc. So you save a lot of surgical time. And when you end up doing it, we borrowed a harmonic scalpel at the time. I think we used Eticon, and we were able to remove the uterus, the ovaries, and put the animal back in the water the next day. So from the welfare point of view and comfort of the patient, it makes a big difference to not have to keep an animal with a large abdominal wound on land. Instead, have very small holes here and there and put the animal back in the water the next day. So it's a big game changer. Something smaller, marmosets. Marmosets are famous for, this should be plain. Yeah. So for having wasting syndromes, and you can go around in circles trying to diagnose why it's wasting, or you can just put a scope in there and look, because that in this case gives an answer that was a bit unexpected. Cholangiohepatitis, you can actually see it. We still sample it. We can take cultures, and we can send for histopath, and we can then verify that our diagnosis and treatment was appropriate for the patient. Here's just an intraoperative view of this red-handed tamarin. You see on a lot of these pictures we have plastic consumables. We're moving away from that as much as possible, and I really encourage all of you to do that. The medical profession is a huge waste generator. Assisted reproduction, big deal in our field. Many vets spend their time stopping animals from breeding. We try to breed them. And in this case, we were doing superovulation, ovocyte collection, all endoscopically, also ovocyte collection. Then we do intracytoplasmic sperm injection to produce embryos. And we would place 4 embryos back through the fimbriae inside the tubes in long-tail macaques. Females were about 2.5 to 3 kilos. The Singapore long-tail macaques are very tiny. This was one of the offspring. You can see here the ovaries that has been collected from superovulating, so there's a lot of injuries to it. And I think now we're about 15 minutes in, so I think we can stop for a Q&A session. You can take really.
Yeah, Paulo, there are two questions. One is, you must have a lot of endoscopes. Which sizes and styles of endoscopes do you find yourself using most frequently in exotic species? For those of us just starting out, which type of endoscope would you suggest we purchase first? I know this is a tough question, probably.
Yeah, it really depends on the type of patients you have. In exotics, or not zoological, but in exotics, most of the animals that come to you are fairly small, and some are very thin walled. And I will show some of the tools later on, so that answer will come later in the talk. If you're looking for something generic, very versatile, reasonably inexpensive to begin with, I would say the 2.7 oblique, 30-degree oblique, with the working sleeves is a good choice. You can do a lot of things with that, both as a GIT or reproscope or as a laparoscope. So that's a good option. I like pediatric instruments. They're light, they're sturdy, and they're in the same catalogs. It's sold by the same reps, so that's a good option. Flexible scopes, it's hard to tell. The silver scope we've been using now for a number of years from stores is very good. But to be fair, there are a number of good flexible scopes out there, and they can be very expensive. So just look for something where you have good support from the rep. So it's not just the equipment itself; it's also how you can look after it and use it.
Okay. One other question was just your sterilization or disinfection technique with your rigid scopes.
Yes, so we try to keep it simple, because also we travel, and like I said, we don't necessarily have hospital resources. We don't use gas sterilization just because the legislation around it and the equipment around it is too cumbersome. So we use autoclavable instruments, and for the vessel sealant that I will show you later on the top, also we chose a unit that can be autoclaved on purpose, generate less waste, and be able to use simple proven technology like autoclave. We also use, we try to avoid sterilizing cables too often. I know that the reps say it's okay to keep soaking those things. We prefer not to, and instead we use wraps. And we also made some thin cloth wraps that we can use as umbilical cords. You'll see some in the pictures later on as well.
Yeah. We've got a couple more questions. I think we'll just do one and then we'll go on. But how can we aim to reduce our use of single-use plastics around endoscopes like you suggested?
Use cloth. So you custom make your own drapes. You know, especially the human consumables are extremely wasteful. They're designed for the first 3 people not knowing what they're doing, and finally in the surgery room they unpack it properly. It doesn't make sense. It comes from the end of the corridor, it's packed 3 times before it gets to the patient. Unnecessary. If one guy works well, you just need one rep. So we try to do everything in cloth that can be washed and autoclaved. Try not to use plastic consumables wherever you can. If you're going to use sleeves all the time for your scope, just make your own sleeves out of drape. You know, it costs a few cents, and then you can reuse them hundreds of times. So at the end, you still save money anyway, and you're not polluting the oceans with your plastic. So basically, also try to harass your vendors. We constantly harass our suppliers and our vendors to ask them for autoclavable or reusable options. For the longest time, people come and advertise things that are double, triple wrapped, and we always shun those and favor the rest. Try to educate the suppliers.
Okay, I think that's it for now. We'll finish up with some of the questions later on.
Yeah, maybe some will be answered there. So some of the other benefits we realized with you started using endoscopy is that being able to bring the equipment to the animal was a big benefit. So when you do procedures, intubation is one of the first things you do. And as you all know, it can suddenly become quite difficult. Things that you thought would take a few minutes, 10, 15 minutes later, you're still trying to intubate. So some animals are more difficult than others. Some situations are more difficult than others. And in this case, walrus, especially subadults, notoriously difficult. And here you see all you have to do is hydroscope inside the ET tube, and then once you're in the mouse, you just watch TV and you can easily get in. So it really shaves off a lot of anesthetic time, and in this case, time where the patient would be apneic. And then you are able to do procedures you didn't consider beforehand. So this is an example of the fact that, you know, once you have scopes of different sizes, or you have access to people who can help you get scopes of different sizes, you can stick them anywhere there's an opening, or you can make an opening if there isn't one. And this is a case of a intramammary parasite in quite common in cetaceans in the wild. This is from a necropsy, a different patient. You can see what they look like, and occasionally they insist and become absedated. This was one of our dolphins that had those, and it was bothering her. She was rubbing on the side, she was slamming, obviously sometimes uncomfortable. We were retrieving lots of eggs that were still vital, that's a vital thing. And so we decided to try to clear it. It was very resistant to, totally resistant to the usual ivermectin and febendazole, albendazole, and so forth. So we decided to use pesticides and to apply them directly in the mammary gland. And by doing so, we realized actually the mammary gland is not as difficult to access as we had anticipated. So we thought, okay, let's put a scope in there and do everything with a visual guidance. So when we tried to retrieve the parasite the first few times with this beautiful scope, it's a very small scope with a big working channel. If the worm was alive, it would fight back or run away. So we decided we'd kill it first with the trichlorophene and go back the next day to retrieve it. And there we had more time to patiently position the tool to snare the parasites and take it out. And that brings also the point that, you know, we're not able to do many, we're able to do many procedures, but not many times. Like this is one that's already 10, 12 years ago. And I haven't done one since, and I might never do one again. So we went in a number of times, but it's just a one dolphin, 2 mammary glands. So it's difficult to build experience that way, and you want techniques that you're able to do a good job without much need for intensive, sophisticated practice. Here you see we're able to snare the worm properly, and then we're moving out of the mammary gland. In dolphins, the mammary gland is inside the little slit on both sides of the genital slit. And then another thing that we do with our patients now with modern training techniques is that we plan the procedures in a way that the animals are willing participants in the procedures. So it's really good for routine examinations or things that require repeat treatments like dental. So we started doing a number of endodontic procedures in our dolphins by getting them used to come and open the mouth for us and so on. And then we realized that we were shooting a lot of x-rays and must have shot my fingers thousands of times by now with the intraoral plates. And also we don't particularly want to then irradiate the trainers who are helping us with the animals. So we realized that by using a little oscilloscope, we could look inside the pulp cavity and decide when the tooth was ready for filling. And then we realized there's some added benefit. This is just necrotic material that would look totally radiotransparent, and it would look like the tooth is ready for filling, but it wasn't, and now it is. So it also adds different layers to what you're doing. And it's fun, you know, we get to recycle all the various needles into protective sleeves for these oscilloscopes, because they're obviously not designed for heavy duty work. Part of these voluntary behaviors that we can do with the animals is that we can do routine examinations. So we train our dolphins to get routine gastroscopies, and they all get that on a monthly basis. And we're able to look in, and then when we have lesions we don't quite understand, we can call specialists. Here is a human gastroenterologist who was happy to come and give us his opinion on what the ulcers would look like. And you can see the patient is just part of the process. This is an example of ulcers that we would see in dolphin. This was a dolphin that was extremely ill, lost about 40% of his body weight, eventually recovered, But you can see here we have, this is the first stomach of a dolphin. You can see we have numerous large, non-healing, deep ulcers. Interestingly enough, the gastric juice is not particularly hemorrhagic, but this animal was obviously becoming chronically anemic and so forth. So these are diagnoses that you can for. This is also another dolphin that had a more hemorrhagic gastritis. This bleeding ulcer here. You can see it's very hemorrhagic. We started treatment, and here is 10 days apart. When we go back in to check, we can be closing the case with a high degree of confidence that the treatment worked, the patient's fine, and so forth. Sometimes combine interest in medicine and curiosity. This is a big boy walrus. It's 1,200 kilos. Anesthetizing this fellow would be a major undertaking and risk. Instead, we trained it to accept rhinoscopy. This was the early stages of training. We used a very small scope and local anesthetic. Afterwards, it would just sit there and accept the scope. And what we're looking forward is little mites. They're very beautiful mites. The adults have these long bridal gowns like this, very numerous. They don't seem to bother the animal much, but we thought it'd be interesting to study them. There's not many good descriptions of it, so we're working now with a parasitologist. We haven't really started treating them yet because we want to make sure we have all the samples we need. And like I said, it doesn't really bother the animal. All these little white flecks that are sticking out are the parasites. They're not very mobile. Obviously, they're in the airways, so they need to hang on. They have very good claws to hang on. And you see minimum damage to the turbinates or the nose. I think most of the redness is from the scope and not from the mite. So this is things that we could not consider without the scope and without proper training techniques. Other advantage of bringing your equipment around is for animals that can't leave the exhibit, either because they're huge, like the walrus, or because, like penguins, they're exquisitely sensitive to aspergillosis, and you keep them. We spend dozens of millions to build an air handling unit that keeps a zero spore count. So we try to keep the penguins in there. And in our facility, most of the lameness in penguins is caused by gastric foreign bodies. The stomach sits at the very bottom in the pelvis, and we think the inflammation of the stomach or the distension causes some mechanical or inflammatory stimulation of the nerves, spinal nerves. Anyway, we get this kind of lameness. And so our go-to examination where we have limping penguins is usually not x-rays, but gastroscopy. And because they're tough little birds and they know us well, we can just grab them, pass a tube to protect the scope and to make it more comfortable for the animal moving in and out. They don't feel the scope anymore. They have a really tough esophagus, a bit like sea turtles. So we put the guide tube in place, and then we can pass. This is a silver scope, 7.9. And in this case, we found a large pin feather. When they molt, they swallow all the feathers, and when you pull it out, you can see there was granuloma and lesions. Typically, within a day or two of removing the foreign body, the lameness stops. So we're quite happy with that. On occasion, they swallow something more tricky. Like in this case, when we went in, we realized there were very large, sharp shards of glass from a spotlight that had broken, and penguins had found it. So obviously, we don't want to fix this with the endoscope. Firstly, because endoscope's expensive, we don't want to cut it. It's too heavy to grab, and even if we could, you don't want to be sliding something sharp through an esophagus all the way through the thin neck. So in this case, we then just scheduled for a conventional surgery, and we removed the glass and the filament. Just a note, now that big electric is replacing big oil in raping the planet, make sure you start getting familiar with metal poisoning, rare earth poisoning, and so on, because that's going to be an increasing topic in rehab and in just in general. So here we have actually time for another Q&A session, and I thought while we do that, we can look at a uterine wash in a largacil that had the dystopia and the phytotomy. And since we were going to wash out the uterus, we thought let's do it also with a visual aid, and then we can have a better idea of what this animal is going to be facing. And we found that actually there wasn't that much damage and we had little to worry about. So I'll take some questions if there are any more.
Yeah, sure. How long does it take to train a dolphin to accept the gastroscope?
It's actually not very long because they already typically trained to accept a tube to collect gastric juice. And one of the reasons we started training them for the gastroscopy is that we were very skeptical. We grew increasingly skeptical over the years about the validity of the gastric juice as a sample, as a routine sample for health assessment. So we decided we would go in monthly, collect the juice directly from the stomach, and look at the stomach and take blood on the same day and try to establish if there was a link between the gastric juice appearance, which is the classic sample taken in dolphin medicine, and what's actually happening. And I must say that we since we're doing that, we put a lot less faith in the gastric sample collected routinely. So it takes anywhere between a couple of weeks in an animal that already knows how to get the tube. And the young animals that are born here, usually by age 2, they all learn to accept the tube. Yeah. So not that hard. Yeah. If you have good trainers, obviously. Yeah.
So one of the other questions is the suspected etiology of gastric ulcers. Is it like Helicobacter or acid, or do you have any idea at all?
I got too many ideas. That's a problem. It's like gastric ulcers. The Helicobacter, yes, they are. The problem is that they're generally there. So if we look for Helicobacter seti, it's a dolphin strain, and if we look for that in the gastric juices, it's typically there. If we look for it from the ulcers or from the histopathology of the ulcers, it's usually not there. And what we find more are infiltrating hyphae, but again, not on every case. I think we're still at a stage where we need to classify the ulcers better, distinguish. It's probably not just one type of ulcer. And probably like horses or cheetahs or humans, it's a species that's quite prone to developing ulcers for a reason or other, and not always very specific etiology. We're actually trying to find partners to help us give names to the ulcers that make sense, and then try to study that in a little bit more consistent way.
Okay, great. Another question was that I suspect in the zoo environment, GI foreign bodies are quite common. Is that true?
It really depends on the zoo. Here it's not very common because we don't have many contacts between people and as in public and animals. In certain places where the pools are exposed, yes. So it really depends on the husbandry. Some species are more likely to swallow things than other, but then some species are likely to swallow and regurgitate easily as well. So it's not necessarily something you have to deal with urgently. I would say we don't see as many as some of our colleagues, and probably not more than you would see in private practice if you're doing dogs and cats. Dogs, especially, that always swallow all kinds of crap. So not really a predominant problem yet.
So one of the question is, do you use any type of sedation, sedatives, or whatever when you're doing conscious gastroscopy?
So that depends on the patient. For the dolphins, if it's a routine exam, we're just going in looking around. Typically not by now because they're familiar with it. Some of the younger animals that are still not trained, then yes, we use typically midazolam IV or IM. And For penguins, no, we don't. Then it's not really a painful or procedure. If we find after going in that we see something that will require a lot of manipulation, a lot of discomfort, then we stop and we plan to go back in under sedation. So for example, the penguin, we go in, we see that, okay, that requires something else, stop, we plan it for a day or two later. Same thing in the dolphin. If we find something that really has to come out, then or we have to take many biopsies and the animal is a bit unstable, then we say, okay, then we'll come back tomorrow or later this afternoon, sedate and carry on. So yeah.
We have one more question, but I think you'll probably answer that as we go on. So why don't you go ahead?
Okay. So specifically on the portability, when you talk to your reps, if you decide to take something portable, make sure they understand the difference between mobile and portable, because this is what most humans call portable. This is not portable in any way. This is not a portable unit. That's a mobile unit. You need a nice flat floor and a lift to carry that around. This is portable. There's a handle and you can carry it with you. And then here, if you allow me a minute to bitch about things, old versus new. I like the old one so much better than the new one. So this is the portable unit from Storz, which has really been a game changer for us. And there's a few things in the new one that I don't support. One is that it's larger. And you can see when we carry it around, you can see this has traveled in many places around the world. And obviously something smaller is easier than something bigger to carry. Then the connection, this one, the new one has the connection from the side, and I just don't understand why you want to add to the space you need to perform. I'm standing in front, so I don't know why this thing can't come from the front, like in the old one. The old one had the screen that can close and is then protected, like in a heavy-duty laptop. This one does not. So this is almost 20 years old, not a scratch. This is 4 years old, nice big scratch. So I really wish we could take this technology, because the image quality is obviously really, really nice on this one. If you could take this technology and put in the old casing, so for the Storz guys, this next one, at least one for me. And that allows us to bring it places. So we can go and help colleagues or either in rescue centers or other facilities, and bring about some of the endoscopic expertise that we've developed, and bring our equipment, because the equipment is expensive. They wouldn't be able to afford it. They might need it just at once. So it's fine to go there with your own equipment and help them out. This is some of the places we've been specifically for endoscopy, from Palau to Botswana, Turkey, India, also Mauritius. Also when we go there, we try always to train people as much as possible and to promote endoscopy, because obviously, you know, when you like something, you want other people to enjoy it too. A lot of the requests we have are for dolphins, clearly, because we've developed a certain expertise. Respiratory examinations are common. A lot of chronic infections that require more sophisticated diagnosis or sampling to resolve. And here you see in other people's facility doing a bronchoscopy. This animal is sedated, obviously, because he had never seen a scope before in his life. That's the larynx of a dolphin. You go in through the top of the head in the blowhole. The larynx, called the goose beak, also for obvious reasons. And then there's a very short trachea. And the rest is just like any other lung. This was a foreign body in a dolphin in another country, in a nice open sea pen, but he had swallowed something that was causing repeat bleeding, chronic anemia, and ill doing. So sometimes you find this was a 3.2 meter scope, very nice, strong piece of equipment, but this dolphin would allow us to retrieve the foreign body past the heart, and then it would swallow it, rip the basket apart, and swallow it back. So we realized that we could get it to a point comfortably, and that once it's there, then we can reach it with our hands. So I guess it's a endoscopic assisted retrieval. So I think the dolphin would feel a bit more violated than if you'd done it just endoscopically. But at the end of the day, you're still able to retrieve the foreign body with minimal fuss. And you can see it was a piece of canvas that was folding, and the edges were sharp and cutting into the wall of the stomach. So that was easily solved. And you can fly in and fly out and then solve the problem with done this with dystochias in dolphins and so forth. rescue center work, just an example, we go to a number of places. This is an example. There was like only a partial success. This is orangutan from Sumatra. The orangutans have a hard time in the natural environment. The plantations are really tough on them. They shoot them and so forth. You can see this guy lost an eye to a pellet and so forth, and he had many other bullets on X-rays. But also, I'm not sure what else happened to it, but he had this really damaged anal sphincter and a prolapsed rectum, chronically prolapsed. There had been a few attempts by other vets to fix it, and it kept recurring. So we consulted here with local human specialists, and they said that the chances of fixing it were not high, but to try this and that. So we went in and we did the lab-assisted PEXI. You can see here we pulled it in, stitched the mucosa, stitched the muscular layer of the gut to the muscle wall on the abdomen. And it looked good for a couple of days. And then it protruded a little bit again. Probably by the time we left, it was out back to a quarter of what it was before we went in. So partial success on it, but it's worth trying. Just to show we can bring the kind of expertise outside. And then while this was wildlife in zoos or rescue centers, what about wildlife actually in the wild where they belong? So I'll have three examples here. One is two are on conflict management and in Hong Kong. So these are cases where we have a lot more practice, like this macaque population control we've been doing now. This is our 11th year, so we've done thousands of these procedures. You can see the fundamental problem is that the macaque population has increased a little bit, but the human population in Hong Kong and the rest of the planet has exploded because I'm not sure why. It seems people seem to think they have to keep going, increasing in numbers. Never mind, bad idea, but it's happening. So what we do, we have these cages set up in the countryside. We have surveyors who go out every day, make friends with the monkeys and teach them to enter the cages. And then when we have sufficient numbers in there, you can see this is something we do every day. So for the monkeys, it's a normal thing. Some of the animals we caught 10 times because they just keep coming back. These are the Hong Kong macaque. It's actually a hybrid. See here, mom with baby, so she's not pregnant, so we definitely want her. And then we lock with this remote control activated. And then once the macaques are in there, it's all under control and we can proceed. So we set up a series of field stations, including the surgery here. There'll be a generator to provide the power for the equipment. And then we have stations where we triage the animals. We find the ones that are suitable candidates. This is how we anesthetize them. Macaques are remarkably good anesthetic patients, so it obviously simplifies everything. This is not something we do. We don't normally intubate ours. This is taken from a place in Indonesia where we went to also transfer the skills and help them sterilize their macaques. And they were keen to also learn other things like intubation and so forth. So we're doing that as well. And then we elevate the pelvis to move the guts to the front, and then we can access. Surgery is very fast. So it's very simple and very fast. So we try to have up to 10 animals an hour on the table. So between animals, we don't really count surgical time. We count time from incision to incision. And we usually try to stay within 6 to 10 minutes interval. And we don't really expect any complications. So this answers one of the questions before. If you use small instruments, these are small 3mm pediatric instruments, get these ribbed sleeves, because for things with very thin muscle walls, like rabbits, like macaques, like cats, these are great. They're very light, so they don't bother you when you're handling your instrument, and they really stay extremely well. We use just a single port because for the camera, because that goes in and out a few times. The other instruments, we just go straight through the wall, and I'll show you it in a minute. If you want more details, you can go and look at this paper. Finally, after 10 years, we wrote it, so I'm advertising. This is also the reproductive system of the macaques. It's very compact, very easy to navigate through. And these are two videos. There's a male here at the bottom right, and you can see that we're getting the vas deferens from the inguinal canal and cauterizing it with a bipolar instrument. And we take the trouble to cut it. Not sure it's necessary, but since we're in there, cutting it, we feel like it gives an extra guarantee that it's not going to become a breeding animal again. On top here on the right, you can see that we grasp the tube. So between the ovary that's here, ovary, fimbriae, uterus. So we grab the tube and cut it off as well. Again, not sure it's necessary to cut it, but why not? It takes a few extra seconds. And you can see that we don't put trocars for these instruments because you're really going in only a couple of times, and it's unnecessary waste of time and bigger incision for nothing. You can see here that's after the procedure, the camera port. There seems to be more damage from the drape clamps than from the actual lateral ports that you can't even see on the picture. And then they're released the same day. So that's really nice because we have absolutely zero post-op concern. You get one shot of antibiotic and anti-inflammatory, and bye. And we keep following them. So these animals we've been following for more than a decade. So we can see we have had so far zero complications. Wild pigs, wild, relative. It's in Hong Kong. The pigs have learned to use the urban environment. These are on the construction site, enjoying the machinery and the equipment. Because people feed them, they develop a number of dangerous bad habits, like soliciting for food, which can be obviously dangerous when you have large animals like that. And unlike the monkeys, where once we catch them in the cage or in the country park, we control everything, with the pigs, we control almost nothing. It's done at night, we have to dart one by one, and there's public all around. So it's quite a different proposition. Bigger animals, so some additional difficulties. We also cannot just dart a mom that has very young piglets, because if they run away, they're too young to look after themselves. So there's an ethics issue here. Whereas if they're already of a certain size, then we can operate the whole family. So if we encounter that, we just wait a couple of weeks and we can go back and do it. This is what the operations would look like at night. Most of the operations are done at night. We weigh them, we move them, do a number of things. You can see the surgical setup at the back here. So ultrasound to see if they're pregnant and so forth. Check if they've been caught before, that the microchip is in place. And this is the surgical setup. So important to have this reclining table, oblique, very much so. It's 60 degrees, so the pig's really hanging from the hind legs and the guts are forward. Here you see in the early days we used plastic, now it's all cloth. Here we had already made the cloth sleeve for the light cable and the camera cable. And this is the vessel sealant. So for this one, because it's a nighttime and we have the issue of manpower, we want a minimum number of people around because dangerous animals. We developed a technique with only 2 surgeons. So here we were still developing it. We're using 2 surgeons, 1 surgeon, 1 assistant. Here is just 1 person needed for the procedure. Again, very simple. It's endoscopy, so it's not much to it. Just get in the right place. As usual, if you get into at the right place, the rest is generally simple. Another difficulty with pigs is that the fat is very oily. So as you go in, it's a bit challenging to get a very, very nice image. We use the Marseille KLS Martin vessel sealant. We tried several brands. I don't want to advertise, but I advertise this one because it's designed to be autoclavable. The handpiece is autoclavable. The blades are replaceable. So it's not wasteful, and it works just as well as the disposable cousins like the Anticons or the Big Assure and so forth. You see it works exactly the same way. We locate the tubes and then apply the pressure. Here the machine will recognize by itself that it's sealed enough and cut it. So really quite simple. And we really do more than one section just to make sure, because it takes a few extra seconds, and at least we have additional guarantee that that's done. This is a boy. We'll do also vasectomy. So vasectomy, we do both endoscopic or just through the scrotum, depending on how many boys are there. Then we can have more than one surgeon busy on it. This was an animal we wasted some time looking at the bladder because he had this funny little Iraqi appendage. But you see here the vas deferens coming from the inguinal ring. Just stretch it a bit. Using just one instrument looks a little bit more clumsy, but it's actually not that bad. Then you can cauterize and resect. You can see this is really quite simple. And I think I'll show you another video here. This is a younger animal, and I want to show this. This is an animal that's not even 30 or 35 kilos, and it's already, you see, it's ovulated profusely. So probably early pregnancy already. There's maybe some capsules there. Embryonic structures for getting ready to produce. These pigs will have 2 liters a year of 8 piglets each time, so it's hard to keep up. Like you see, once we do that, then they won't breed for sure. And we're not sure yet because this project is only 3 years old. But we think the actual lifespan of the pigs is quite short in the wild. The captivity, they will live to a couple of decades. But studies done in wild populations suggest that they actually don't live very long. And from the dental conditions of the animals we see, we seem to think it's true that most of the animals are young animals. So anyway, more of the same, you can see. So yeah, if you're looking for equipment that is not disposable, I would recommend this one. We've used it now for several years and I'm very happy with it. Lastly, something truly in the wild this time, in Botswana, in the real wild, not the wilds of Hong Kong. This was a project with NIH at the time when they were studying HIV and doing that through the cat model of FIV and looking at the natural mutations and resistance of the different organs to the virus and so forth. So very complicated science. We were just collecting samples for them. We practice on our lines in the zoo, and then we transfer that know-how to the field. See, we get there, we have to find a dry strip to land, bring in the equipment. So you want to bring equipment that's sturdy and reliable. Military, South African military vehicle that was adapted to be a surgery suite. Fortunately, it was a little bit too short. It was missing 5 centimeters for me to stand straight. Proper anesthetic equipment, and this was the instrumentation, 10 mm. For large animals, please always use 10 mm scopes, because if you use the 5 mm, when you use it, you'll end up breaking your instrument. It's not worth the hassle. This is small enough for a large animal. Don't worry about the size of the hole. This is what the ambulance looked on the inside, the mobile suite. See, we didn't have the fancy telepack there. There was equipment bought by NIH. And they had followed the recommendation from the old equipment we had before the portable units came available, but it worked fine. Portable enough, I would say. And then the principle is the same, always look for the animal, find the animal, capture the animal, and once you have it in hand, chase the friends away, and then once you have the patient in hand, start working. Equipment must be ready and working, and then you prepare the patient. So this was our prep room, this was our anesthetic suite, and this was our surgical suite, and this was the power cord to the generator. Quite a very neat setup. And then we set up the animal. This was a really wonderful anesthesiologist that was on the project. And here collecting endoscopic samples. We collect a bit of everything: spleen, liver, various lymph nodes, kidneys, and then we would go back the next year from the same animal, collect the same samples, and see. Then they would study how the virus behaved in between organs and within the organ. Collect all kind of other samples, CSF, and even pop prints. I'm sure what that was doing, but once you have it in hand, enjoy. And yeah, that's it. So after a hard day for the people and the lions, then go back and socialize the same day. And it's a way to bring sophisticated expertise and equipment to places where you wouldn't necessarily expect it to be accessible. And I think that concludes my promotion of portable endoscopy for zoological medicine. Thank you, and we can take more questions. This is a larger seal pup, just born, and this is a red-eyed tree frog with a cyroscope.
Well, that was really great, Paulo. There are a couple of questions that actually both relate to insufflation. One of the comments was with the macaques, it appears you're using gravity and not CO2 for insufflation. Is that the same for the wild boars too?
No, we use both. We use gravity to keep the organs away from the surgical field, and we use insufflation to make room. So insufflation, my go-to number is 12, and then I adjust intraoperatively. So for the pigs and the macaques, 12 is fine. For koala, for example, we started with 12 and we ended up having plenty of room with just 6. So you can adjust as you go along. Marmosets, I start with 8 because if I put it on 12, my machine delivers very big bursts, even at a low setting, and then it takes longer to inflate. So you can adjust it. Every animal is slightly different, but my go-to number is 12. And I use CO2 all the time, and I don't, as often as possible. It makes extra room. It makes the procedure faster and even simpler. Yeah.
Okay. Another question is, how do you balance insufflation pressure while providing adequate ventilation during reptile laparoscopy?
During with what? Sorry.
How do you balance insufflation with ventilation in reptiles doing laparoscopy?
Okay. So reptiles are great because reptiles don't really need their lungs to get rid of the CO2. A lot of the CO2 gets out from the skin. So that's one added benefit. You don't, unlike mammals when you're doing procedures that last a little bit, then you really have to rely on the ventilation to get rid of the extra CO2 that goes through the blood in a very circuitous way. In most reptiles, most of the CO2 just gets out from the skin. So that's one less concern. So the ventilation, you can just focus on your anesthetic level, or desired anesthetic level. And I use the ventilation then just frequency rather than concentration to keep the plane I want. So it's not something that I'm concerned with. Basically, that's the answer.
Okay.
Yeah, go ahead.
No, one more question for someone is, have you ever tried the smart scope? And I'm not familiar with that scope, so
I don't know what the smart scope is. I try to use the scope smartly, but I don't know what the smart scope is. I have a little tool that connects to the iPhone for the dentos, the little oscilloscope that we use for the dentistry.
that's the smart scope.
That scope comes from with a little light extension, and we can put an iPhone adapter there. I don't know if that's what they're talking about. Otherwise, I haven't heard of a smart scope. Sorry.
Okay. Well, that's it for the questions. I guess I have one question. In Botswana, when you were in the pool, enjoying, relaxing, enjoying the beer, were there hippos around?
Those were shallow pools, so they were just crocs. But we just drive through a few times to scare the crocs away, and then it's safe. Yeah.
Okay.
Yeah. The hippos choose the deeper pools.
Okay. Well, Paulo, I really want to thank you for a terrific presentation, and we really appreciate you doing this Endoscopy Talks program. So again, I'd like to thank the audience for attending as well. In 2 weeks, we'll learn about the ins and outs of elbow arthroscopy presented by Dr. Mark Glyde, who's the head of orthopedic services at Murdoch University in Perth, Australia. That session will be on Wednesday, June 2nd at 8 p.m. New York time. So we look forward to seeing everyone then. And in the meantime, wishing everyone the very best. Thank you.